Hello, my name is Devin Fuller and I'm a student at Bladen Community College. I'm currently enrolled in the online portion of Biology 168, also known as Anatomy and Physiology 1. My instructor is Mrs. Pamela Locklear-King, and the following presentation is our Week 5 labs, which includes a videoed presentation of the appendicular skeleton as well as the skull. Thank you. So when we think of the human skeleton, or just the skeleton in general, we don't often think about what function it actually serves. And the primary function, of course, that, if we were to think about it, that it would serve would be for our form and our structure. Now, the skeleton has two different variations, or I guess you can say the human body has two different skeletons, one being the appendicular skeleton and one being the axial skeleton. Now, the axial skeleton actually fits along an axis. It's the head and the trunk. It's the version of the skeleton that's most responsible for not just having our appendicular skeleton or appendages attached to, but it also serves to provide additional protection for our most vital of organs, mainly our heart, our lungs, and our brain. Of course, the heart and the lungs being back behind the sternum and the rib cage, and the brain being in the skull. And of course, the lungs, you have 3 lobes on the right, 2 lobes on the left. You also have the heart that's in the mediastinum, which is the middle area that's directly behind the left side, and substernal underneath here, of course this being your xiphoid process on the bottom, and your brain being encased in the skull, which this guy, you can kind of take it off, but hopefully it's not that easy in real life. It's not. So I have a list of a few areas that I want to speak of and talk about right here. I don't have any locations as to where they're actually listed, but if we talk about the appendicular skeleton, that of course being your appendages, the areas that actually attach to the trunk or the thorax and some of the lower vertebrae, as well as the skull, you have your arms and you have your legs. Now, everything that's formed in our body is bilateral, meaning that there's one on the left and one on the right. And with the skeleton, it's no different. The only difference is technically back in the vertebrae, where you have these pieces of bone that come off in the very back in your vertebral column, and it comes out to protect the spine from any type of external force that comes in. Hopefully the bone will break and your spinal column will not. So I want to zoom in on the top of the humerus right now so that we can take a look at that. So let's see, I'll raise this up a little bit. There we are. Alright, so if we're looking at the humerus from this angle, we can see that there's a little shadowy indentation that's in here. Okay, this shadowy indentation is in here because of these two bony prominences that are coming out. Okay, this one being the lesser tubercle, this one being the greater tubercle. Now, the reason why these bony prominences are so important is so that we can utilize these as landmarks when we do additional interventions on patients in the pre-hospital field. Several other fields have several different reasons, but the main reason why we do it is so that we can place something called an IO, or an interosseous needle. There are other means for us to administer medication, IV, IM, or intravenous, intramuscular, sub-Q, or subcutaneous, which is directly under the skin, as we've already covered in the previous chapters. We also have sublingual, transdermal, PO, or oral medication, PR, we won't go into that. But we utilize these bony prominences as we palpate or feel around the humeral head, or the tip of the humerus, so that we can position the humerus in the appropriate way, which this skeleton won't do that, and we can place an IO needle in the general area. Technically it's right about here, where the flat part of the greater tubercle is. And we are able to aspirate some bone marrow and are able to push medication that way. But if we come down and we continue down the humerus, down the diaphysis, the metaphysis, towards the epiphysis, we have something called a trochlear. Now the trochlear is down here. Now underneath the trochlear, where the ulna is, you have this little indentation here. I'm going to double check on camera and see if you can actually see it. There we are. This little area right here, which is a fossa, or an indentation inside the bone. And this is your olecranon, which is the very bottom of your ulna, or the most proximal tip of your ulna. And this olecranon fits into this olecranon fascia. Now, of course, your elbow, this middle tip right here, is the very tip of your ulna, or the most proximal portion of it. And if you think and have an easier way to remember, you have your radius, which will sit on top, and you have your ulna, which is underneath on the pinky side. Okay. Now I've had to highlight a few of these, or your wrist bones, so you can actually see it. So I'm going to adjust the camera real quick and adjust down so that we can see those and cover those as well. So looking at the wrist bones, as I bring this one closer to you, hopefully the camera will start to focus a little better. There we are. Okay, if we look at the wrist bones, we see that there's several lines that have been drawn in between them to better highlight them. Of course, there should be a line underneath here where the pisiform is, but these will be the 8 bones in the wrist. If we start from the thumb side, we'll see that this outermost prominent bone right here directly underneath the thumb is noted as the trapezium. Okay, it is kind of in the shape of a trapezoid, but it's not the trapezoid because the trapezoid is actually right next to it. Okay, and it is closest to the finger. All right, the middle finger comes down and attaches to the capitate. Okay, and if you look here, you see this little junction that's between these two. All right, between your pinky and your ring finger, which these, of course, are your carpals, and then you have your metacarpals, and the most distal tip of your fingers are the phalanges. But you have the trapezium, the trapezoid, the capitate, and this right next to it is the hamate. Okay? And directly underneath the hamate, of course, the best way for me to remember is that if you look at it from the side, it kind of looks like a ham. But directly beneath the hamate, as I said before, is the pisiform. Okay? And you can't really see it on this one, but right next to the pisiform, directly underneath it, is the trochetrium. All right, and that's a little bone that's kind of deep underneath in this area. All right, then you have the lunae bone, which when you take it apart and you look at it, if you look at it from this angle underneath, which you're not able to see on this dummy, on this skeleton, the inside of it, where it attaches to the capitate, looks almost identical to a crescent moon or a lunar shape, lunae. And then, of course, in between the lunae and the trapezium is the scaphoid bone. And like I said, that also attaches to the carpals, to the metacarpals, the carpals, the metacarpals, and to the phalanges. Okay. Now, if we zoom out a little bit and take another look at the radius and the ulna attach to the wrist. One main area is via the styloid process of the radius, which is located in this area right here. So, I'm going to keep the camera a little bit here, kind of zoom out just a tad, and try and see if I can hit the pelvis from a different angle. So, I can move this guy's arm out of the way. When we look at the pelvis here, we see that the femoral head is attached into this little junction that's in here, or as it's called, the acetabular junction, where the femoral head actually fits into the acetabulum, which is this bone that's inside at the very head, or at the very middle portion right here of the pelvis. Now, this is another very prominent feature. If you notice, if you can see close enough, that this is flat right here. This entire area is the iliac crest. Okay, and the iliac crest is another area where we can insert an interosseous bone once we find that flat prominent surface. And we can go a couple different areas in here, but we want to find the flattest, most prominent surface that we can. Iliac, of course, being this bone here. And underneath, we have the ischium, which is here, which attaches to, or helps the pelvis, or the pelvic bone, attached to the pubic symphysis, or the pubis bone, the pubis bone. Okay. And then we have, of course, several foramens, which are just holes, and this one is known as the obturator foramen, which is in between the ischium and the pubis. Okay. Now, if we go back to the femur, let me double check my camera angle here. There we are. We'll just move your hand back here, and you can grab that one right there. You won't do it. All right. So if we go back to the femur, we notice that there's a couple other bony prominences on the lateral side as well as the medial side. Of course, we have the femoral head as well as the neck of the femoral head, which attaches the femoral head to the femur being the strongest long bone in the body as well as the largest long bone. It takes approximately 1,800 to 25 pounds of pressure to break the femur. So we know if we roll up on an accident or the scene of a traumatic injury, we know that if they have a broken femur, there's a high index of suspicion that there has been some sort of potential for internal organ damage to the trunk, potentially to the head, maybe a head injury. And we'll also look at the mechanism of injury, which is anything that can cause a high mechanism, which would be a massive car wreck, a motor vehicle accident versus a motorcycle, a pedestrian hit, and several other things that we take into account when we come to pre-hospital emergency medicine. But instead of it being a tubercle, this is called a trochanter. Okay, we have the lesser trochanter, which is the medial side, and we have the greater trochanter, which is on the lateral side. Okay, and if we continue down, which we'll go ahead and do, if we continue down, then we will start to look at the lower portion of the lower limbs, the very distal. Okay, and once we get to the tibia, we'll note that if you see close enough, it does look a little triangular in shape. Let's see if I can zoom into that. Move this guy back a little bit. It does look triangular in shape, as you can see. You know, and this triangular shape is known as the anterior crest. Okay, so when we're looking at the anterior crest, we want to palpate until we find the tibial tuberosity. Okay, once we locate the tibial tuberosity, which is this area here, once we locate the tibial tuberosity, we'll go 1-2 finger breadths down to the flat portion of the tibia here. That's another placement for interosseous infusion. Of course, the femur and the tibia and fibula are both connected by another joint, and this is the patella. The patella is held together, held to the femur and the tibia by the patellar tendon. And if we continue to go down, we will see the feet. Yay for feet. So once we come down here, we'll note, of course, that we have the tarsals, the metatarsals, and the phalanges, which we have phalanges up top, and we also have phalanges down below. And then we have this bone down here, which is known as the talus bone. Okay? And we have this other bone that kind of forms underneath and then goes up and is responsible for our heel, and this is also known as the calcaneus. Okay? And then, of course, we have the phalanges. As I said before, we have the metatarsals and we have the tarsals. We have several different bones that make up the feet and actually allow us to have structure. Now, if you actually do a count on the bones, you'll note 1, 2, 3, 4, 5, 6 versus the articulate 8 that we have, which I'll have to adjust the camera angle on that. The articulate 8 that we have up in the hand. But this has been a brief overview of the skeletal structure, and this is the completion of lab number 2. Thanks.